Good morning. So today's topic for my seminar is hypersensitivity reactions. So hypersensitivity reactions are exaggerated or inappropriate immune responses to antigens that lead to host-specific tissue damage, and they are classified into four types, as we all know. It is type 1, type 2, type 3, type 4. Type 1 is IgE mediated, that underlines anaphylaxis and allergies. The type 2 is antibody mediated cytotoxic hypersensitivity. It involves IgG or IgM against the cell surface antigens. The type 3 is immune complex hypersensitivity. So the stems from deposition of antigen antibody reaction complexes. The type 4 is delayed or cell mediated hypersensitivity. It is driven by the T cells and the macrophages. So each type has a specific distinct effector and mechanism, clinical manifestations and diagnostic approaches for understanding these critical for targeted therapies. So I will be talking about each in detail on these topics: hypersensitivity types, the clinical examples, the mechanism, diagnosis, and the disease, and the how to treat or immunotherapy. So coming to the type 1 hypersensitivity, it is IgE mediated. It involves a rapid allergic reaction that occurs within the minutes of exposure to an antigen that is also called as allergen. It is mediated by the IgE antibodies that are bound to the mast cells and basophils. Upon the re-exposure, the allergen-induced cross-linking of surface-bound IgE that triggers the release of histamines and other inflammatory mediators. So for type 1, the histamine and other inflammatory mediators are the key molecules that will produce the hypersensitivity reaction. So this will result in symptoms like vasodilation, bronchoconstriction, and increased mucus production. So clinical examples is such as we all know people have allergy to peanuts and asthma. So these are some of the examples. The symptoms will manifest within few minutes, and it will lead to vasodilation, bronchoconstriction, and urticaria. So the mechanism of type 1 sensitization to an allergen will induce the Th2 cells to secrete interleukin 4, interleukin 1-3, driving the class switching between IgE. So the other immunoglobulins will switch to IgE in the presence of interleukin 4 and 13. So IgE will bind to Fc epsilon Ri on the mast cells and basophils. So it's a receptor, it will bind to the FcRI receptors. Upon re-exposure, cross-linking of bound IgE triggers degranulation, and this degranulation will release histamine, leukotrienes, and prostaglandins, causing vasodilation, edema, and the smooth muscle contraction. Diagnosis: skin pricks testing can be done to diagnose this hypersensitivity. Serum specific IgE assays, rash or tryptase levels can be assessed for diagnosis. Some common disease that are caused is like anaphylaxis, may be caused due to food or insect or venom bite. Allergic rhinitis, also known as hay fever, atopic dermatitis, and asthma, also known as allergic bronchoconstriction. So the treatment, how we will treat this, it is by epinephrine for anaphylaxis, omalzumab, it is an anti-IgE monoclonal antibody. It will reduce the free IgE and downregulate the FRI or receptors on effector cells. So allergen specific immunotherapy, subcutaneous or sublingual desensitization. This can also induce regulatory T cells and shift the antibody isotype towards the IgG G4. Coming to the type 2 hypersensitivity reaction, it is antibody mediated. So this will occur when the IgG or IgM antibodies will bind to the antigens on the surface of the cells or extracellular matrix components. So these antibodies may trigger complement activation, the activation of complement system, and opsonization or antibody dependent cellular cytotoxicity. So this will lead to direct cell lysis or cellular dysfunction. The clinical example is autoimmune hemolytic anemia, Goodpasture's syndrome, Graves' disease, rheumatic heart disease, etc. Mechanisms, so the IgG or IgM antibody will bind to antigen on cell surface or extracellular matrix, leads to three things. First is complement system activation via classical pathway, then second, antibody dependent cellular cytotoxicity, and third, opsonization and phagocytosis. So how is this diagnosed? There are two direct and indirect Coombs test. It will help to diagnose this, as well as complement levels and autoantibody panels can be done for testing. Diseases, so certain diseases like autoimmune hemolytic anemia, that is like anti-RBC antibodies, Goodpasture disease syndrome, myasthenia gravis, Graves' disease, etc. So the immunotherapy is rituximab. It is anti-CD20. It depletes the B cell and it is used in autoimmune cytopenias and pemphigus. The IVIG, it provides antibody to idiopathic antibodies. It provides anti-idiotypic antibodies and FCR blockade in immune thrombocytopenia and hemolytic anemias. Complement inhibitors prevent terminal complement mediated lysis in the paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome. The type 3 hypersensitivity reaction, it is the immune complex mediated hypersensitivity. Here, soluble antigen antibody complexes formed in the circulation and deposit in the tissues such as blood vessel walls, kidneys or joints. So these deposits will trigger the complement activation and recruit